to be about the systemic therapy for advanced biliary cancer. Next. Next slide, please. So this is my overview. I'll be discussing some of the diagnostic challenges related to biliary tract malignancy, also the options of the first-line therapy, as well as the second-line systemic therapy, and some of the future perspectives. And there will be more dedicated lecture by Prof. Ghassan Abu Alfa in this regard. Next, please. So we all know that biliary tract cancer is not just a disease. It is actually a group of diseases that include the cholangiocarcinomas, either intrahepatic or extrahepatic, as well as the gallbladder malignancy. And in general, we are dealing with a majority of the tumors here are adenocarcinoma, with a few adenosquame and rarely squamous cell carcinoma. If you look at the incidence and the risk factors, they are very similar, with very minor differences when it comes to gallbladder malignancy. So a patient with gallbladder cancer seems to have a risk factors of obesity, as well as diabetes and chronic or recurrent cholecystitis. On the other hand, for the intrahepatic and extrahepatic cholangiocarcinomas, they share the risk factor of a primary sclerosing cholangitis, as well as some known liver flukes that could be a source for or a risk factor for cholangiocarcinoma. Predominance is mainly in males, except gallbladder cancer, where the females are more predominant to have gallbladder cancer. Next, please. So it is a rare tumor, and the incidence is actually increasing when it comes to intrahepatic cholangiocarcinoma. Remember, we are dealing with a very aggressive type of tumor with a poor prognosis, and this is likely related to the late presentation. Majority of the patients presented with advanced disease, and even if they present early and underwent a surgical resection, the recurrence rate is high. And these all contribute to the poor prognosis. So their 5-year overall survival does not exceed 20%. So the goal for the advanced cases here is to really palliate their symptoms and also to try to improve their quality of life, as well as prolongation of life. But one of the important palliation here is to relieve the pain, as well as to relieve the biliary obstruction. So there are ways of relieving the obstruction, either by doing the surgical bypass, but preferably to consider and to go for percutaneous or endoscopic drainage and relieving the obstruction by endoscopy or by PTC, because we are dealing with a aggressive tumor where we need to start patient as soon as possible on systemic therapy. Putting patient on a surgery may really delay the options of systemic therapy. Next, please. So the challenges that we face with diagnosis are many. The most important challenge is actually the delayed diagnosis itself. So patient comes with non-specific symptoms that lead to a delay in presentation and delay in diagnosis. Even jaundice or obstruction of the biliary system sometimes comes very advanced, especially with the extrahepatic cholangiocarcinoma. Remember, we do not have a specific population at risk, so we do not have adequate screening, and that is why we cannot identify the high-risk group at earlier time, so we can offer them a curative intent option. Next, please. So remember, again, one of the diagnostic challenges is that cholangiocarcinomas and gallbladder cancer, especially cholangiocarcinoma, they share similar geographic area with other tumors there, like the head of pancreas, ampullary cancers, HCC, or even carcinoma non-primary. So the diagnosis sometimes can be challenging. And even when you look at the intrahepatic cholangiocarcinoma, it can share similar enhancements in the imaging with the HCC, and even sometimes we call patient carcinoma of unknown primary, and there is a misdiagnosis of about 20% in literature where cholangiocarcinoma can be called carcinoma of unknown primary. Next. Remember again, HCC is accounting for 90% of the liver malignancy, especially when we are dealing with a liver cirrhosis. And the rest is intrahepatic cholangiocarcinoma. But again, if a patient has a cirrhotic liver, may really develop a similar vascular pattern, and in this condition, difficult to differentiate between the HCC and intrahepatic cholangiocarcinoma. So at this point, biopsy is needed. Next. So initial consideration when we talk about advanced biliary tract cancer, remember chemotherapy is the cornerstone treatment here in patients who are fit. And the chemotherapy is not really bringing any impressive outcomes. The best median survival achieved with systemic chemotherapy is about 12 months. And unfortunately, many patients cannot go for second-line chemotherapy or even systemic therapy in second-line setting. Only 15% are able to go because they have a rapid clinical deterioration. And one of the issues that we face all is the challenges with the biliary obstruction. So the obstruction can recur again despite stenting and despite bypass procedures. If you look at the literature, there is a data about the median time to stent-related events, which is about 4.5 months. So even when you put your patient on systemic therapy, there is a chance that there is a events or stent-related events can happen again, like obstruction or ascending cholangitis, where you need to put patient again on the table to exchange the stent. So there is maybe a better option of a metallic stent to be inserted prior to chemotherapy to try to reduce the risk of stent-related events. Next. Next. Next slide, please. So patients who have a good performance status, the best option that we have is the gemcitabine-based combination, especially when we have a patient with no high bilirubin or minimal hyperbilirubinemia. There are many options, but the best studied option is the gemcitabine and capecitabine and cisplatin. So cisgem is the better option that we have nowadays. However, there are many other options like just gemcitabine and capecitabine, or even gemcitabine and S1 in some places of the world, or even JMOX. Next, please. Next slide. So this is the well-known ABC02 trial, phase 3 trial evaluating the cisgem over the gemcitabine alone. And in this trial, the patients were mainly bile duct carcinoma or gallbladder cancer, and very few of them had ampullary carcinoma. Next. This is the outcome. So you can see here that there is a significant improvement in overall survival. Can you go back to the, yes, overall survival benefit from 8 months to 11.7 months. And the progression-free survival has been also improved. And you can see that the benefit was seen across all the subgroups. Can you move the slide forward, please? Yes. Next slide. Next. All right. So another small study. The slides are not fixed. Can you fix the slide, please? Yes, this one. Now go back. Yeah. If you look at the a smaller trial, so this is the ABC trial, but a smaller trial from Japan, the PTs 22, showed a similar PFS and similar overall survival. This is a meta-analysis that included these two trials, and it showed a similar benefit with regard to overall survival, hazard ratio 0.65. So there is no doubt that cisgem is the best option that we have nowadays. Move. Next. There are some patients who may really benefit more from systemic therapy. This is a analysis including 3 large trials of the cholangiocarcinoma, and seems that the intrahepatic cholangiocarcinoma seems to do better with regard to overall survival, and mainly those who have a liver predominant disease do better when compared to other types of biliary tract cancer. Next. Gemcitabine plus S1, the oral fluoropyrimidine, has been shown recently to be non-inferior to the standard of care cisplatin gemcitabine with similar overall survival and PFS. So it is an option, especially in the places where the oral S1 is available. Next. This is an data that actually combined S1 plus the cisgem. So in this phase 3 trial, patient randomized to gemcitabine, cisplatin, or gem cis plus S1. Next. And there is a trend, some improvement in the overall survival and PFS, although the benefit is very modest. But what has been noticed that the response rate and disease control rate were much better with the triple therapy, the cisplatin, gemcitabine, and S1. Next. One of the options also is the gemcitabine and oxaliplatin if there is a clear contraindication to cisplatin or carboplatin. This is data from India evaluating the modified JMOX with a lower dose of gemcitabine and oxaliplatin compared to gemcitabine and cisplatin. They had a similar response rate, a similar overall median overall survival, but the numbers here are smaller than what has been observed in the ABC 02 and in the meta-analysis. Next. For patients who have a persistent biliary obstruction or persistent hyperbilirubinemia, it's better to avoid the gemcitabine if possible, and then the options are either single agent fluoropyrimidine or fluoropyrimidine with oxaliplatin. Next. This is a data about the K-box in the first line setting, where this trial showed that the K-box is non-inferior to gem and oxaliplatin, the JMOX, with a higher response rate, but there is no difference in progression-free survival or overall survival. Next. So majority of the patients, when they come actually with a borderline performance status in the clinic. So you sometimes cannot offer them a combined option. So the option is actually single agent, either gemcitabine or capecitabine, especially if we are having a hyperbilirubinemia, or again, the best supportive care, which is a good option for such patients if there is any doubt that chemotherapy will cause harm. There are multiple small trials showing a clinical benefit of single agent gemcitabine, ranging between 15 and 60% with a median survival of 11 months. For the capecitabine, there is a single report of a 63 patients showing a response rate of 50%, but there was no response recorded in the cholangiocarcinoma. Remember, this is a single study, so cannot really draw a strong conclusion when it comes to cholangiocarcinoma. For the biological agents, next. So for the biological agents, there have been many trials evaluating the addition of anti-EGFR monoclonal antibody or tyrosine kinase inhibitors, either EGFR TKIs or VEGF TKIs like sorafenib. And you can see here that the median overall survival did not change significantly with the addition of these biologics to chemotherapy alone. Next. So moving to second line treatment, remember we said in the earlier slides that there is approximately only 15% are able to go for second line therapy. So when we have still a patient who can go for second line, we need to offer them a drugs that does not really overlap with the first line to try to avoid the cross resistance. The best studied regimen in the second line setting is the FOLFOX. However, there are many other options like immunotherapy in a specific group of patients or even single agent chemo. To select patients for second line therapy, there are some independent reviews stating that some predictives can tell us whether those patients will benefit or not. For example, good performance status, also patients who had a long disease control on first line chemotherapy, and those with a low CA19-9, and also those who have resected primary tumor. But to tell the truth, whether we don't really know whether these variables are indicating responsiveness from chemotherapy, or it's actually indicating that we are dealing with a favorable biological behavior of a tumor. Next. So until recently, many small clinical trials, including phase 2 trials, showing a response rate of 7 months and survival of 7.2 months. Next. The best evidence that we have is the FOLFOX from the ABC06. And in this study, patients who progressed on a cisgem were randomized to active symptom control that include biliary drainage, antibiotic, steroid, plus or minus modified FOLFOX. The primary endpoint was overall survival. Next. So there is a improvement in the median overall survival by about 1 month. However, the 6 months and 12 months survival rate were improving by about 15% between the active symptom control or active symptom control plus modified FOLFOX. Next. The best group who benefited are those who had a platinum resistance. They had a better outcome with chemo, with FOLFOX. Also those with a low albumin and those with metastatic disease. So those who carry poorer prognosis seems to benefit more from aggressive approaches like chemotherapy. Next. Now we move to the second line option, the immunotherapy, and immunotherapy is acceptable and good option actually in the tumors that carry mismatch repair deficiency. And this is a data from 84 patients that included 12 different tumors, including the ampullary tumors and cholangiocarcinoma. Their response rate to pembrolizumab was 54% with a CR of 20%. And the same group did a very good work by screening about 12,000 tumors. They found 3% of the cholangiocarcinoma are having a MSI high or dMMR. There is another report from the Memorial Sloan Kettering Cancer Center that the ICC seems to have a higher incidence of the MSI reaching 10%. Next. So the options here is the pembrolizumab or even nivolumab. So there's a phase 2 trial including 54 patients, and in this trial, all patients should have at least one line of treatment. Their primary endpoint was investigator response rate. The response rate is at 22% with a median PFS of 3.5 months and long survival of 14 months. The benefit was seen mainly in the PD-L1 enriched group. Next. The dual IO is an option, and this is based on a small trial of 39 patients where the disease control rate is 70%. But remember, the combination is actually
1 minute.
The combination is actually sure. The combination is associated with immune-related adverse events, and this was unselected group of patients. So we are treated based on no PD-L1 expression or MSI status. Next. What else? There is a phase 2 trial of cisplatin, gemcitabine, and nab-paclitaxel that showed a very impressive overall survival of 18 months. This is phase 2, and based on that, there is ongoing phase 3 trial. Next. So this is the SWOG 1A215 trial, including the evaluating Gem-Cis plus nab-pacli or Gem-Cis alone, and they are still recruiting. Next. So precision medicine will be discussed in the next slide. This is a very good work from the Moscato group, where the patients were evaluated for druggable mutations. The most promising is the IDH and the fibroblast growth factor receptors, and this is more prominent in the intrahepatic cholangiocarcinoma. Next. This is data about the bimigratinib that showed a good survival in patients with a FGFR mutation. Next. And there is ongoing two phase 3 trials evaluating the FGFR gene fusion or gene rearrangements by using bimigratinib or infigratinib. Next. So to conclude, when we have a patient with advanced disease, they account for 70% of our patients. Then the first line palliative therapy that we offer is the best is the cisplatin and gemcitabine. And when patient progress, the second line option is the FOLFOX for those who are fit. Remember, immunotherapy is very important in those with MSI high or the MMR. And NGS testing is very important to identify any targetable mutation like the IDH mutation or FGFR fusions. Next. So to conclude, the diagnosis is challenging for the PTCs. There are different clinical and molecular subgroups identified with a potentially prognostic and predictive implications. The well-established first-line chemotherapy is cisplatin gemcitabine, with unfortunately minimal improvement over the last decades in this field. The second-line chemotherapy is FOLFOX with some OS benefit, as well as immunotherapy. And the targeted treatment seems to be promising, and we are awaiting for the first-line trials for targeted therapy in this regard. Thank you.